Welcome to Pulse and Pressors, where critical care gets crystal clear. Dopamine is an older catecholamine with dose-dependent receptor activity. Although historically central in ICU care, its modern use has declined due to safety concerns and superior alternatives. Pharmacologically, dopamine acts as a precursor to norepinephrine and interacts with dopaminergic, beta, and alpha receptors depending on dose. It is metabolized by MAO and COMT, giving it a fast-acting but short-lived profile. Dopamine demonstrates dose-tiered effects, dopaminergic vasodilation at low doses, beta-driven inotropy, and chronotropy at moderate doses, and alpha-mediated vasoconstriction at high doses. Clinically, these dose boundaries are less reliable than textbooks suggest. Indications today include bradycardic shock, where chronotropy is needed, certain cardiogenic states, and post-CABG low-output physiology. Dopamine may be used when norepinephrine is unavailable, but this is increasingly rare. Dopamine's benefits include improved heart rate, modest inotropy, and some vasoconstriction at higher doses. It was once widely used for shock, but evidence has shifted practice decisively. Standard dosing of 2 to 20 micrograms per kilogram per minute requires careful titration. With lower doses, 2 to 5, primarily producing dopaminergic renal and mesenteric vasodilation. Mid-range doses, 5 to 10, generating beta-1, inotropy and chronotropy, and higher doses, 10 to 20, triggering alpha-mediated vasoconstriction and increased systemic vascular resistance. Physiologically, dopamine increases heart rate more than blood pressure, raising myocardial oxygen consumption. This can worsen ischemia, particularly in cardiogenic shock. Dopamine frequently triggers tachyarrhythmias and is associated with higher mortality compared to norepinephrine. High doses can cause peripheral ischemia and irregular end-organ perfusion. The hemodynamic profile is inconsistent because SVR response varies widely. Tachycardia, however, is consistent and may destabilize patients with limited coronary reserve. Compared with norepinephrine, dopamine has worse mortality outcomes and a higher arrhythmia burden. Its instability and side effect profile make it inferior in most shock states. In cardiogenic shock, dopamine may be useful when bradycardia significantly depresses cardiac output. However, it often worsens ectopy and increases oxygen demand, making it a poor fit for most patients. In mechanically ventilated patients, dopamine-driven tachycardia increases oxygen consumption and may worsen ventilator desynchrony, complicating respiratory management. In mechanical circulatory support, dopamine's chronotropy reduces diastolic filling and worsens LV distension. Norepinephrine or epinephrine are more stable and safer for MCS patients. Renal-dose dopamine is obsolete. It provides no renal protection, does not prevent AKI, and introduces unnecessary arrhythmia risk. Monitoring includes heart rate, rhythm, MAP, SVR trends, urine output, lactate levels, and overall perfusion. Dopamine demands closer watch than more stable vasopressors. SOAP-2, DeBacker 2010, was the pivotal RCT comparing dopamine and norepinephrine. It showed more arrhythmias with dopamine and higher mortality in cardiogenic shock. This study fundamentally changed vasopressor practice. Dopamine's pharmacokinetics include rapid onset and peak effect, but short half-life, leading to rapid shifts in clinical effect. This contributes to its unstable hemodynamic profile and makes it harder to control than norepinephrine. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.